We are privileged to have Dr. Bonakdarpour and Ms. Clara Takarabe to join us today. Please join me in welcoming them to the podium.
Hello, everyone. What a pleasure it is for me to present to our own people. Yeah, you've known about our work, and many of you know about it in fragments, but this is a great opportunity for me to show you what we've been doing during the past 5 years. So let's dive into it. This is my disclosure and our funding sources.
See Henry inert, maybe depressed, unresponsive, and almost unalive.
Henry.
Yeah.
Henry.
Yes, sir.
I found your music. You want your music now?
What do you want me?
Let's try your music, okay? And then you tell me if it's too loud or not.
Then he is given an iPod containing, we know, his favorite music. And immediately he lights up. His face assumes expression, his eyes open wide. He starts to sing and to rock and to move his arms, and he's being animated by the music.
And he used to always sit on the unit with his head like this. He didn't really talk to much people. And then when I introduced the music to him, this is his reaction ever since.
The philosopher Kant once called music the quickening art, and Henry is being quickened, he's being brought to life.
Yeah.
I'm going to take the music for 1 second, okay? Just to ask you a few questions. Okay? I'm going to give it back to you.
Uh-huh.
Okay.
The effect of this doesn't stop, because when the headphones are taken off, Henry, normally mute and virtually unable to answer the simplest yes or no questions, is quite voluble.
Henry,
Yeah.
do you like the iPod? Do you like the music you're hearing?
Yes.
Tell me about your music.
Well, I don't have one, I mean.
Do you like music?
Yeah, I'm crazy about music. You play beautiful music, beautiful sound. Beautiful.
Did you play music when you were? Did you like music when you were young?
Yes, I went to big dances and things.
What was your favorite music when you were young?
Well, I guess, Cab Calloway was my #1 band guy. I like it. That did the hold it, the holly, the hill, the hold it, the mill it, the holly, the
So isn't that precious? These are the moments that I've seen a lot using music in different neurologic disorders. And that was one of my drives to do both since I was in medical school. And, billions of dollars are spent on coming up with new drugs. But while we are trying to, change the course of the disease with disease-modifying drugs that we are hoping that we can come up with, I, as a clinician, have to deal with and troubleshoot with problems with dementia every day. And, one of the things that I use, we do a lot of non-pharmacological interventions, and one of them is music, which is underused. So I'm going to show you what we've been doing at Northwestern and where we're going in terms of research and education. And this is the outline of what I'm going to talk about. So we're going to start with a little bit of anatomy. Hearing and hearing processing has been not quite paid attention to because, we always say, out of sight, out of mind. But there's so much to the hearing and so much that actually centrally changes in patients with neurodegenerative disease and in the neurologic disease in general. And then I'll talk to you about some therapeutic interventions and what we've been doing here at Northwestern. So the processing of hearing is very unique. Unlike other senses, the sound gets to go through many stops before it actually gets to the cortex. As you see from the cochlear nucleus until it gets to the cortex, you have at least 4 or 5 stops, during which some of the sound differentiation can happen. There's evidence that our voice and our language sound gets discriminated even as early as in the brainstem, and then it gets relayed to the left hemisphere and right-handers. The other thing that gets processed is the localization. The semicircular canals and the cochlea are together, so the processing of movement and balance starts with sound and then also with tones and music. And then what's really fascinating looking at these connections is as early as in inferior colliculus, which is very much involved in our spatial navigation through hearing, you see some feet forward here to the visceral and motor system. You know, when I clap like this, you know, you may jump, and that's what happens right at the brainstem level. And then some of the visceral changes also happen with that. You know, you get the autonomic response to the sound right away. And then later, you see that a big part of music, of course, is or sound is also processed by the mesial, frontal, and the anterior amygdala and the anterior connection of amygdala. On the lateral side, I mean, I've been working so much on language and the lateral part of the temporal lobe. And if you just open the temporal lobe, you see all the hearing-related, auditory-related areas. The facial gyrus, the planum temporale in the back, which is mostly, you know, it taps into the phonology and then the timing on the left side, and the planum polare, which taps into the limbic system, into amygdala, into hypothalamus, and the semantic system. And like language, you have the dorsal and ventral pathway of processing of sound. Through the dorsal pathway, you tap into the spatial, to visual, to auditory motor, auditory executive, and auditory language areas of the auditory connections. And then there's a big part of these connections that are dedicated to social cognition, as you see here in the anterior temporal lobe, and the mesial frontal lobe, and anterior insula, and orbitofrontal cortex. But technically, music is processed eventually by the whole brain through these different networks. This is a paper from Neurology a few years ago that shows you how, you know, we have the auditory motor pathway, auditory limbic, somatic motor, visceral motor, and then, you know, the vestibular pathway. And so one major thing with tone, music, and rhythm is the phenomenon of entrainment. When you listen to a music that has certain rhythm, the brain tends to sync with it. Not only with that, the study here shows that even the tension and release in music, through the harmonic tension and release, that by itself can create entrainment and synchronization. So we'll see how that works in the trial that we are doing later. But and then a lot of this is already wired in our brains. And this is my younger son, 1 year old, and then I was pleasantly surprised how he actually responded to rhythm. So this is in all of us. I mean, there are cultural aspects to music, but they are components that we all process the same. And I wanted to show you a little bit about the neurotransmitters that are used in research for music interventions. So dopamine and endorphins are a big one in the reward system. And there's a lot going on now at NIH level in terms of the effect of music in both emotions and mood, dopamine reward, and then also endorphins, the internal endorphins and for pain management. So there's a lot of, we will talk about the 3 networks in NIH that is working on it. Also, acetylcholine itself has a role in auditory processing. And no wonder in Alzheimer's, we do have some central auditory processing changes. Serotonin reduces tension, it enhances mood, the secretion is increased with rhythmic music. And arousal, of course, if you have an upbeat music, it's going to wake people up. And then GABA for the calmness, and that's technically throughout the nervous system. And hormonally, the two that has been studied have been oxytocin, which affects our human connection, social bonding, and trust. And then the cortisol, which can have both effects on regulating immune response and boosting it. And that's what's been studied so far. There's been many studies showing the role music can play in increase through the hypothalamic axis and changing the cortisol level and secretion of IgA and regulation with IL-6, TNF-alpha, and IL-10. All right, so let's talk a little bit about therapeutic intervention. And let's go back in the history. And I thought Clara, my great collaborator, who's also a philosopher, would be a better person to talk about this slide.
Hello, everyone. Thank you so much for having me. So in the ancient literature, it's been well noted that there's been a lot written about its role in praise and ceremonial events or liturgies. But also there's a lot written about how music has the capacity to alleviate pain, emotional distress, and also social pain. In the Bible, there's a passage about David and Saul. Here it is. When this evil spirit from God was upon Saul, David took a harp and played with his hand, so Saul was refreshed and was well, and the evil spirit departed from him. So this, in my opinion, is about emotional regulation. Another passage, Orpheus taming the beasts from the 7th century BCE in southern Anatolia, now Turkey. Music was so powerful and enchanting that it could charm not only humans, but also animals, even wild ones. And my favorite is Plato. Music is centrally embedded in Plato's theory of civil governance. And I think this is really enigmatic. I imagine some of you have read his Republic here. And it's such a beautiful work and also very troubling. Why is this the case? In his laws, there's a very famous passage in which he describes how the mother calms an agitated infant. She doesn't calm him by just holding him passively, but she holds the baby and rocks the baby vigorously to match the level of agitation, and then changes the rhythm to be slower. So this would be instance of external imposition of rhythm leading to emotional regulation. I don't think Plato would have said it that way exactly, but this would be a mechanism involving the brainstem. Plato socially prescribed music from birth until death and believed that there were many levels of emotional regulation to be taught through frequent engagement with music. His understanding of how music worked was sophisticated. Individuals experienced music-based emotions at a remove from daily life. And this experience, he felt, supported the learning of interoception, meaning this is our ability to sense ourselves both physically and emotionally. With interoception, he believed this led to higher cognitive abilities, metacognitive abilities such as self-assessment, self-correction, contemplation, and evaluation. And without these capacities, he did not believe society could possess justice, and justice is learned through lifelong engagement with music and the lifelong practice of emotional regulation. This is perhaps one of the earliest works expounding social prescription, which is now practice adopted by the World Health Organization.
Thank you very much. So fast forwarding, so as you see, music has been used forever for emotional regulation. It almost grandfathered into medical practice. And you see a picture from 1950s, and then this is when it's in hospital music. You see National Association for Music Therapy, 1950. That's when it started its work. Now, the major association is American Music Therapy Association. And then there's been a lot of case reports and case series until, this is about 2000, when I was working on my dissertation, and I was very encouraged to see, JAMA wrote an article about how music therapists started clinical trials at the time. And, talked about the fact that, and then that's still the case. You have about 8,000 music therapists in the United States. They're underused. You have 1,000 music practitioners. And there are many areas of medicine that music can help with patient care, neurology and psychiatry being the most. In neurology, in stroke, Parkinson's disease, multiple sclerosis, sleep, dementia, in psychiatry, and medical conditions, pain, pulmonary, and vascular disease. The major thing was really to figure out how to reimburse these services through insurance by providing more data and also by showing target engagement and biological measurements. And again, going forward, in 2017, this paper published in Lancet Neurology, summarizing a lot of the clinical trials that I was looking forward to in 2000 in a beautiful paper, encompassing all the areas of neurology that I told you about. There was a table in it that I thought we should go over, because it's not the fact that anybody who can play can go to the hospital and play for patients. It doesn't work that way. Music therapy can only be done by a credentialed music therapist. So that's what music therapy is called. That's a clinical entity. They're licenses, and Illinois. I was behind a movement that we try to get certifications for music therapists in Illinois, and then that was passed. And then hopefully very soon Medicaid will cover some of the music therapy services. If we are using music as in research, we call it music-based intervention, MBIs. Music medicine is when music is used as, for example, concerts or in clinical settings by clinicians. There is no direct goal or direct interaction with the patient, but there is a health outcome that we are expecting from the music. And then there's also music-supported therapy that is used in rehab, for example, stroke and paralysis, where you can, for example, teach the patient to play if they have a paralysis in their hand, and then use music as an adjunct. So, I've seen music therapists and occupation therapists and the physical therapists working together to help the patients with stroke, for example. And the field was really energized in 2017 and 18 when Renee Fleming, who was the artistic director of Kennedy Center, worked with Francis Collins, the director of NIH, and they did a workshop. They invited all the music neuroscientists from around the United States and started two initiatives or let's say one initiative and a network, Sound Health Networks through the NIH, with about $20 million for research, and then also Sound Health Network through National Endowment for the Arts. And it was interesting. They performed together. There's not time to listen to the whole performance, but this is what they sang the Leonard Cohen's Hallelujah. Now I've heard there was a secret chord that David played, and it pleased the Lord. So they referred to the story of David and Saul. 2018, Nina Kraus started the first music therapy conference at Northwestern in Evanston and invited the leading researchers and clinicians in the United States. It was very, very inspiring. And that was really, it boosted the idea for me to start the musical medicine program, because we thought we have it all here. NIH has been uh, holding many webinars and conferences to really enhance the field by including the biomarkers and, and more controlled trials to show the efficacy of music, and also for us to understand how music is processed clinically. This was one of my favorite ones, the target engagement that was aired in 2021. And during the pandemic, Renee Fleming worked with a lot of these researchers on podcast type interviews, which later turned into Music and Mind book. And then Daniel Levitin, another great music neuroscientist from Montreal, put together another book that came out recently. And NIH in 2023 started 4 networks. One, Music and Dementia, which I'm honored to say that we are very much involved in at Northwestern, and we're probably the only one in Illinois. And also 3 networks for pain, Music for Pain Ensemble and Audio Analgesia, because we really believe that these interventions help patients. I wanted to show you one of the interventions that I myself did research on, which is called melodic intonation therapy. Many of you have seen it in the hospital, patients who have left-sided aphasia, left-sided stroke and aphasia, and then they can sing. And then that can be used to rehabilitate patients. So this is a patient with severe apraxia of speech and non-fluent aphasia.
Yeah.
So when you start intoning the phrases that the patient needs, in this case, really multisyllabic words,
Hello.
then you see they can actually say the word.
Hello. Hello.
And then if you work with people on multiple sessions, eventually you can increase the syllables and then the complexity of the grammatical complexity of the sentences.
I and juice.
And then later in the course of the intervention, the therapist tries to take a back seat, and then the patient will try to independently produce the phrases.
What's your name?
I and juice.
I found this very fascinating, and then that's why I did my doctoral dissertation on this for Persian language, which, for each culture, you have to use the appropriate language, appropriate music. This has been replicated in many, many countries, many, many languages. It improves phonemic, phrasal, and grammatical production. And then meta-analysis that came out a few years ago shows that it has a positive role in improving trained and untrained phrases. That's very important for it to generalize to what's untrained. And I had another experience with it when I was doing my residency in Tucson, Arizona, where Gabrielle Giffords was shot in the head. And I was part of the team who was taking care of her. And she had a non-fluent aphasia, severe apraxia, and so we started some of the treatment there, and then she was moved to East Coast to work with my mentor, Nancy Helm Estabrooks. And then, so it took her a few years, and then 2016, she showed up at one of the Congress sessions and was able to recite the sentence that were written for her. All right. So after the music therapy conference in Evanston, we flashed into COVID. It was frustrating, but it was also an opportunity. We had a lot of patients who were stuck in the wards. They couldn't have their family members. We were trying to do something for them. And then I talked to Carrie Ann, our department administrator, and then Dimitri, and then we tried to, we got some funding to do 3 months of intervention for these patients. And I had been working with Clara on the music intervention research. This was a great opportunity because musicians at the time had all the time in the world. And then so she played for about 120 patients in the neuroscience unit. It was an amazing experience. We got to know what type of music our patients like based on their age. And then you see that, you know, the classical and jazz would be more for the middle age and then older people. And then pop and rock, for example, in younger people. When you use music for interventions, it has to be personalized. You can't just use anything for everybody, except for some exceptions. And as you see, we got a lot of media hype about it. We did some post-intervention surveys, and then the feedback was great, which really energized us to move forward with doing more. We published this in Frontiers in Neurology in 21. And one thing that Clara noticed was not everybody or everybody's agitation would respond to their favorite song or favorite music. So then we thought about doing improvisatory music, which is completely neutral. And there are certain elements that Clara will talk to you about that she used to calm these agitated patients down. And this by itself was a source of another line of research that I'll talk to you about. But let's hear from Clara and then hear some of the music.
So during this pilot, it was a really interesting period where we were asking ourselves what it is that patients in the neurology and their neurosurgery ward needed. And in light of the pandemic, there was just so much going on in terms of psychological distress, and we really didn't know what was going on with COVID also. And so when we combined the social isolation with pandemic protocols, we thought that the patients were feeling a lot of fear. They weren't feeling safe, and no one was feeling safe. And so that led to a research question: can we design a type of music that evokes physical sensations of safety? And so that was a super exciting research question, and that led us to create this. We created a type of improvisatory music that was in a very limited range between one octave above middle C and 1 octave below. It's very slow, no fast rhythms or complicated rhythms. The music came in statements, about 1 to 2 minutes. And at the end, there was a very slow decrease in volume to silence. And then there was about 10 seconds of silence, which we hypothesize stimulates the default mode network.
So Clara played for one of the EMU patients, and that was, you know, this was not a study at the time. You know, it was a clinical intervention, and then he almost slept, and then you left the FaceTime, and then so we had the video, and then he woke up and said, "That was really good. Where is she?" So it was very actually, and then that actually gave us another incentive to do research in the EMU. You know, we looked at individual people to see how their blood pressure, heart rate, and then some of the somatic symptoms they had during the pandemic changed. And then you see that with the music, the heart rate and blood pressure comes down. And then as you see in this case, for example, the effect can last for a few hours after. So these are points that we know we pay attention to in terms of dosing and then the frequency that we need to use this intervention. Again, that was unbelievable. What happened was I talked to Stefan Choulet. I don't know if he's here. Can we use the EEG data from the EMU? And he said, actually, yes, we do have an IRB. We can use everything. And so we had about 5 patients. We had 8 patients, but 5 of them really we could use the data to see what happens during listening to CDM, clinically designed improvisatory music. And then what we found was the concentration of alpha wave goes up in the whole brain, and then specifically in certain areas. And no wonder where, it would be the medial, frontal, and midline areas of the brain, which is exactly where you have the default network and you have the salience network. So the social and emotional and memory networks of the brain. And the effect, as you see, persisted afterwards, for 20 minutes. We looked at 20 minutes. We can look further. So we're going to do more of this. We have an IRB now. We're going to start as a clinical trial, looking at it with a control group very soon. The other thing that was very interesting was the dosage. So Clara played for about 40 minutes. But then we realized when we are looking at the density of, so this is alpha over beta. As the alpha goes up, it kind of plateaus after about 15 minutes. So 15 to 20 minutes seemed like a good dose of this music. We didn't have to do it. And that can help us in terms of when we are budgeting, for example, in grants. The other thing that happened during the pandemic, the Northwestern Wellbeing, I got into the Scholar of Wellness program, and to do music for our colleagues here, for residents, for health providers, for our colleagues in the hospital. And we started the recuperation room in the physician lounge. I think those of you who've been there, you've seen it. At the time, we couldn't have live music, of course, because of the pandemic, but we had recorded music, which we had it as a QR code. And we held a couple of sessions for our faculty on Zoom for the same, calming music, and for our residents. They just had another session 2 weeks ago. They loved it. We have the surveys. And then, we started doing this in conferences. They loved it too. So we did it for 4 years. We've been doing this at the AA, and we kind of present our data, and then also there's a restorative music session for about 20 minutes. As you see, they lay down, they have fun, relaxing. And then same thing with ANA. ANA again invited us this year. So I think people like it. And then we had some data we collected sorry, let me see, where was it? Okay, I think we will get to it. So by 2021, I thought we were ready to have a program at Northwestern. There are many other universities who have institute centers, programs in music and medicine. Hopkins, NYU, Florida, Case Western, Houston, UT, UCLA. So we were kind of behind. At the same time, that was a great opportunity. And then our goal is to bring music as a clinical intervention, and also to look at the efficacy of music through trials, and also look at the mechanistic effect of music so we can show target engagement using biomarkers. All right. In terms of dementia, there's been a lot of research. You go to any memory facility and there's a music therapist there. The Cochrane review in 2018 evaluated these studies and showed there's moderate effect on depressive symptoms and dementia. There was improvement of emotional well-being and reduced anxiety. What they couldn't comment on was social behavioral outcomes. And they recommended future studies to examine the duration of effect, as I was telling you earlier, what the dose has to be, how long does it last, and So that's the part that has not been investigated as much. And then NIH, with the movement that I told you about, specifically is focusing on in addition to the above, on the mechanistic underpinning and the target engagement. So since 2020, 2021, we've been involved in 5 projects. One is a music medicine project, which is what we offer to the patients and their caregivers. It's a program. I called it Musical Museum. And then the reason I called it that was we had a lot of non-pharmacological interventions at our center. Dr. Darby Morhart is here, inspired by some of what Dr. Morhart had been doing, and some of them involved being in a museum. And then also we have the lifelong learning at Northwestern, which is great for patients with dementia, but it has to be designed for them. And we didn't have anything like that. So I thought we can combine music and talk about these phenomenal pieces as a brain stimulation and also emotional social support. And then we started a trial on clinical improvisatory music in Alzheimer and caregivers. There's another study I've been working on it in memory facilities, musical bridges to memory. There is an amazing group singing with 8 choirs in Chicago area that I've been working with. We're going to go through these very quickly. And music empathy treatment in FTD, which is fascinating. It's the work we are doing with University of Chicago. So Musical Museum is a disability-informed series of concerts with discussions. They are short. They are about 40 to 45 minutes. And we discuss the music, and then we play. I play, and we have eminent musicians. It takes a lot of work, as you see, and we have a team of about 10 people at least each time going through all the details. And it's all funded by philanthropy. Patients wanted us to do this, and then that's how we kept doing it. And then two of my favorite ones were the last one that was done in the south side of the Timothy Center. And everybody, our regulars who come here came, and all the locals came. We had about more than 80 people showing up. And then you see the number of people who have been signing up and coming to our events have grown. And then we do get surveys afterwards too. The other one was our 10th event, which was covered by NBC. We had an international singer, and then I got to be in a Italian magazine. And our surveys, we kept it simple. We wanted to know their general satisfaction. I know NM likes LTR, likelihood to recommend, so we use that. As you see, the LTR is pretty high. People found it pleasurable. That's a main thing in music. The intellectual part always scores a little bit lower because people with dementia, they are reluctant to the cognitive aspects of interventions. But again, it's still above 4 in the Likert scale. And then we asked them to tell us how did they generally felt before and after the session. And then you see it's significant statistically. And we do have, critics too. But this is including the critics that we have. And the Clara talked a little bit about the social prescription. And I think if you want to maybe talk a little bit more about it. So this enable us to actually check in with people. Our wait time in the clinic is long, but I see my patients a lot. We have now these programs 5 times per year, and then we hope to have it monthly. But this is an opportunity to kind of check in with patients as well. So Clara is involved in this effort, and I'll let her tell you more.
So a little bit about social prescription. It emerged in the United Kingdom in the 1980s and 1990s as the government was recognizing that there was a shortage of clinicians, and also that medical treatments alone were insufficient for addressing many health conditions which were linked to the social determinants of health, such as environment, economic status, and cultural factors. And so social prescribing, the way it works is that it is a non-clinical service or intervention. A clinician identifies that a patient is maybe socially isolated, having depression or anxiety related to something that has to do with SDH. And so they give the patient a prescription for art. And then the patient takes this prescription to basically a social worker that is art oriented or community oriented. And for example, if the patient is a 16-year-old adolescent female with depression, the research in arts and medicine show that group dance is most effective for such a case. And so this patient will be recommended group dance, but she does not have to take that recommendation. She should say, I'd rather go to the theater. I want ceramics. And what happens is that Medicaid will pay for 2 engagements for this person and their friend, so they don't have to go alone. They'll pay for the transportation. And then there is a record that they attended and maybe some feedback from the venue or the provider. So it's kind of an additional way that it's feeding into the system of care. And so far, we know that there will be a large shortage of clinicians in the future. There already is now. And so this is another way to provide support non-medically. And this is already happening in the state of Georgia. There is a large state-based public health pilot in Massachusetts. Parts of New York are getting it, and we are working on getting it here so that Medicaid insurers could provide that.
We're going to get it approved for Illinois soon. All right. So just wanted to show you a little bit about the research we've been doing. So this one is musical bridges through memory for moderate to severe dementia. We had, and it's ongoing. We got some philanthropy funding in the beginning, and then it was supported by ANEA. We have 2 arms, a control which gets the regular care at the facility, and another arm that participates in music with an ensemble, with percussion music, dancing, and these are people who have apathy. They can't get along with their spouses, with their care partners. And then when they go through this three months of interventions, we were able to show that actually their nonverbal sociable behaviors stayed stable while the control dropped significantly. And the caregiver distress went down significantly, while in the control group, it went up significantly. This was on 30 patients and 30 controls. We have another probably 20 to 30 that we're going to add to it. And so the idea is eventually to have a phase 3 clinical trial with placebo, which we're going to be working with some biomarkers. With the CIMAC, Clinical Improvisatory Music for Alzheimer's and Caregivers, anxiety is very common in dementia. There's been work in anxiety through music. Our goal was to define how the music should be, because especially improvisatory music had not been used that often. And when it was used, we couldn't tell exactly how it was done. So the characterization of it is very important. We have a great postdoc in my lab, Melanie Zhang, who's now working on defining how, because when Clara improvises, that's beyond science. And it depends on her interaction with the patient. But then we are measuring these ups and downs and the rhythm changes to see exactly what's done. And then now we are recording with wireless EEG to see what happens in the patient's brain. In the CIMAC trial, which is an NIA-funded trial, we try to look at brain networks. You know, I'm a neuroimager, so I love to look at it. And then specifically, we found that the planum polare, which was anterior to the Heschel gyrus, is very much, if you put a seed there, there's a great connectivity with the limbic system. So I thought this would be a great target. And then also reward network, the default network, and salience network, which are involved in anxiety in Alzheimer's disease. And there are 2 studies, not too many studies in care partners, but the studies have shown that the frontal and then right temporal areas are involved with the burden of care. And the right-sided, right hemisphere symptoms in the patient correlates with the caregiver's burden, which is very interesting, you know, because there are a lot of behavioral issues. And so what we've proposed so far is 30 patients, and the Osher Institute covered the funding for the care partners. The study has a delayed enrollment. We measure how they're doing within 4 weeks before and after that, and then before and after 8 sessions of music, which is in person, and so 4 sessions in person, 4 sessions virtual. And we do fMRI before and after. And our primary outcome measure for patients has been rating for anxiety in dementia. That's a very commonly used measure. We expect it to go down. We also measure secondarily some of the vitals and resting state functional connectivity. For partners, Zarit caregiver burden is very commonly used, and then we use that for the measurement. We expected all the connectivities to go down except for the salience network. Kate Vidano is a student in my lab, neuroscience student in my lab, is doing a great job. And then as you see, as she analyzed the data, the ZBI, the burden goes significantly down. And this is just for now in 10 patients. So this is an ongoing study. And then we do see changes. So this is after 8 sessions. Immediately after the music, you of course see changes. Everybody knows that. What I was impressed by was, after 8 sessions, you do see some changes in vitals and in, what subjectively patients or caregivers report. And you would think that that would be because of some network and neurotransmitter and hormonal changes, which Dr. Vassar recommended for me to look at more biomarkers, and we will be doing that. In care partners, we saw increased connectivity in the posterior part of the default network, which correlated with the ZBI. So that was nice. We expected for that to go up. But what was very also interesting, because this is association visual cortex. And then what Clara mentions for each of these sessions is people have a lot of imagery. And so maybe the imagery is helping them kind of detach themselves from the burden of the care. And then the other thing that we see is increased connectivity with the auditory cortex and the frontal lobe, which it's too early to over-analyze this, but I think it could be related to executive control of all these subcortical areas that are hyperactive in people who are, anxious and burdened. And then also what with music is always shows up, which is the right-sided, temporal area, which is related to social cognition. I mean, everything music is more than one person. It's a connection. It involves a social entity and social cognition, even if you're listening to the music. These are the atrophy maps. We had 2 groups of patients, one with typical Alzheimer with atrophy within the hippocampus and entorhinal cortices. Some patients didn't even have atrophy because they're so mild. And then we had 2. One was primary progressive aphasia. The other one was posterior cortical atrophy, visual variant of Alzheimer. So interestingly, the vitals don't respond the same way in patients as in the caregivers. And especially we had different phenotypes. One of them, the PPA patient, also has Lewy bodies. So the response in the vitals will not be the same. And also a lot of them are on Aricept. So that would kind of confound our findings. But they were ones, I think out of 6, 4 of them do show what we expected, which is, these are the measurements during the sessions, 8 sessions. And then you see this was a very anxious gentleman. He even had hospital admission, ED visits, and then as you see, there's a lot of ups and downs. We thought, oh, we're not going to get anything out of this. But you see, the pressures gradually went down, and then his evaluation was positive. In patients, we saw, again, increased auditory limbic connectivity, this time not in the default network, but in the salience network and in the reward network. So as you see, because in default network is abnormal in patients with Alzheimer's, we don't see much changes in the default network. Again, this is 6 patients. We still need more subjects to be definitive. And Again, during the pandemic, I saw the Sounds Good Choir at our Alzheimer's Day conference. Dr. Morehart invited them. And I always, it was mind-boggling to see how patients with dementia, I mean, how do you even work with them to learn a song, to sing together? But the way they do it is they are with the care partners and the number, there's strength in number. There's 50, 60 of them. So nobody, you can't hear everybody in detail. And then what the sound that comes out of the course is amazing. They did an amazing job during the pandemic, putting all these people together to sing together. And as you know, you can't sing on Zoom together. So they had to work with them separately and then send them the tracks to rehearse. And then eventually they had the 3- and 4-part choruses. We thought we should look at the methodology and then some of the data with survey data that we distributed. It got a very complicated study because there was a choir and there was a sing-along. And each group had older adults and neurocognitive disorder patients, dementia patients. So great opportunity to multiple comparisons. We sent them this was during the pandemic, so we couldn't be too burdening on people. So it was 6 questions: anxiety, social connection, physical well-being, and other things. These are the pillars of well-being in general, and we take care of people's well-being. So the responses were, and then we had high, low satisfaction, and no satisfaction. And then we did a probability analysis, and as you see, for anxiety, social connection, and physical well-being, we were above chance. And we had more people above chance in the high probability group. And what was interesting was there was a higher satisfaction of the sing-along program, as you see here. That's the bright gray, because it was easier. People just had to sing, and then they didn't have to meet every week to learn the pieces. And during the pandemic, maybe that was what was more important for them. And there was really no difference between how they liked the program between cognitively healthy and dementia patients. In the open-ended questions, the 3 themes that came up was emotional, social, and intellectual well-being. And when we went over the responses, the cognitively healthy people and choir people would always talk about how they liked the intellectual stimulation, and the patients and liked the sing-along and connection to pass. So those came out as significant. For patients in dementia, we know that they do better with autobiographically based music. So, and that was what sing-along was about. So this kind of gives us an idea of what type of music and what type of program can be done for what group of people. And then in this case, in the virtual choir, and that would be for people who are in the rural area, some people who don't want to be around 50, 60 others, they can use the virtual choir, which they actually, sounds good. They held some of the virtual rehearsals, and it's still ongoing. All right, so just to summarize, we talked about the NIH NEA Sound Health Network and Initiative and the effort that has really energized us. And we are going full force with that. So we are in the 2nd year of the Music Dementia Research Network. We are writing a paper, a white paper, and then there are pilot grants that we are still waiting to hear about. Our meetings have been canceled too, so we are still waiting for the meetings to pick up as well. MBIs can be used as indicated in patients with neurologic diagnoses. There's so much I couldn't fit here for this talk, but I'm happy to answer any questions. What our goal is really to conduct more phase 3 clinical trials with placebo-controlled groups and biomarker target engagement research. We have some preliminary results that are positive for our CDEM intervention for anxiety and Alzheimer and caregivers. And then CDEM has been helpful for individuals in the healthcare. I think the slide for some reason disappeared. So we had data for about 400 people, and the response has been overwhelmingly positive. That's why we kept getting invited to ANA and AAN. And so we are going to be working towards a fully funded program, hopefully, and a center. And we are collaborating with many people. Renee Fleming is now a friend of us. She's going to be in town in Evanston next week. We are honoring her for her work and her support. She resigned from Kennedy Center recently. And then we had a roundtable that I had the honor to be part of. Our president, Northwestern president, was on it, the dean of School of Music, who's very supportive of this initiative. And we are also working to see if we can find funding to have music therapists at Northwestern, NMH. Lurie has had this for 25 years. Why not us? I think we definitely need to have that. And we are working with the placebo control trials and the mechanistic research through MDRN, Music Dementia Research Network. Pepe Contreras and his team from University of Houston, who do wireless EEG recordings. They were in town. We invited them last month, and then we recorded a lot of data, so we just need to analyze them now. And this is me with Julian Johnson and Julian from UCSF, where the MDRN is placed. And then we had our first course in music and medicine this year with our students. And these are all the people who, without them, this would not have been possible. Very enthusiastic folks. And everybody in the bottom, if they didn't exist, this would all fall apart. Dr. Kranz, Dr. Meselam, Karian, Dr. Weintraub, everybody. And these are our funding sources. We have 2 upcoming programs. One is next week and another one end of this month. And I'm happy to answer any questions. Dr. Vassar. Yes. Well, we haven't gone there. We haven't gotten there yet. So right now we are fit. How long to follow people? That's a great question. I think we should really follow people at least for 6 months. At least for 6 months to see how long the effect of the music will last.
Great.
The question is, do you do a round of interventions and then stop and then reevaluate and repeat it? Or do you have to do it like drugs? Do you have to continuously do it? We don't know that.
And what are your biomarkers that you're going to be looking at?
The biomarkers, of course, we're going to look at some of the batteries for anxiety and cognitive batteries. We are going to look at the network batteries. We can look at, of course, we can look at beta, amyloid, and tau. We can look at the biomarkers, the neurotransmitters. We can look at oxytocin and cortisol. There are also wearable devices with John Rogers. We've talked to John Rogers about, we can actually monitor how people are doing, even outside the session.
It would be interesting to look at fluid biomarkers, like for amyloid and tau.
Yes.
And, but you're going to have to follow them for a long time,
Yes.
maybe 18 months or so. The question is this a disease modifying effect or is it symptomatic?
We don't know. There was one of our candidates for our imaging court, and I forgot her name. She showed some data about people who had certain amount of education or cognitive stimulation, that their amyloid level was lower. It was not a control, it was a retrospective report. But I found that very fascinating. I don't know if there will be any disease modifying. We definitely know that in terms of cognitive reserve, these interventions help with symptoms to progress less rapidly. Any other questions?
I was just asking at which point it can affect other population of cells within the brain, because you make a big focus on the neurons here.
Neuroinflammation? Oh, that's definitely something we want to look at. Dr. Grabenchikova was here. And one of our residents, Dr. Stephen Beezer, is very interested in it. There's definitely a role in the immunity. And Dr. Vassar too, I mean, we have to really pick which ones we want to look at, or all of them. Those people have looked at, the interleukins and TNF and things like that as well. So we can, and then we know that, for example, in Alzheimer and in a lot of neurodegenerative diseases, inflammation has a big part, definitely. So those are, these are great ideas to think of as we think about biomarkers we want to use for our next level.